Background monoclonal antibodies are broadly tolerable and have good clinical effect. They are specific and powerful treatments for autoimmune conditions, skin diseases, cancers, and other illnesses. They are synthesized as chimeric, humanized or fully human antibodies. Although fully human antibodies tend to provoke the least immune response, adalimumab is capable of provoking antidrug antibody responses in some patients with rheumatoid arthritis. In some cases, they are the first new treatment for a disease in years. Because of this, they are sometimes afforded fast track or breakthrough therapy designations by the FDA. Although rare, some patients experience life-threatening adverse effects such as myositis and encephalitis. These have led to permanent or temporary recalls of drugs such as degli. Classical hypersensitivity reactions to monoclonal antibody therapy are broadly like those of other drugs. Manifestations of hypersensitivity reactions typically occur within 6 hours of drug administration and include cutaneous, cardiovascular, gastrointestinal, and neurological changes. Delayed hypersensitivity reactions include DRESS syndrome, Stevens-Johnson syndrome, vasculitis, and maculopapular eruptions, among others. Autoimmunity diuretics and anticonvulsants appear particularly likely to cause DRESS syndrome. The mainstay of treatment is discontinuation of the offending drug and initiation of systemic glucocorticoids, although there may be multiple relapses after discontinuation. One reported case of DRESS syndrome presented with widespread maculopapular exanthem and lymphadenopathy 54 days after treatment of basal cell carcinoma with vismodegib, which was approved in 2012. In this case, a lymph node biopsy showed marked eosinophilic infiltrate in the absence of cancer cells. A retrospective cohort study of patients treated with vemurafenib, a BRAF inhibitor, one case of DRESS syndrome, leading to permanent discontinuation of treatment. DRESS syndrome drug reaction with eosinophilia and systemic symptoms. DRESS syndrome is a hypersensitivity that can be easily missed due to its long incubation period and nonspecific presentation. The incubation period of DRESS syndrome is 2 to 8 weeks, and the emergence of symptoms is thought to be connected to reactivation of latent human herpesvirus 6, although the exact mechanism behind this reactivation is unclear but may be related to T-cell activation. Multiple studies have estimated the mortality rate of DRESS syndrome to be approximately 10%, but the severity and extent of cutaneous involvement do not always correlate with those of the internal organs. Patients with DRESS syndrome typically develop pyrexia, diffuse rash, pruritus and papular, pustular, or vesicular erythema. Hematologic manifestations include lymphadenopathy, thrombocytopenia, and lymphocytosis, while eosinophilia is not universally present. This has contributed to the multiple naming practices for the disease, such as drug-induced hypersensitivity syndrome. Approvals before 2015. Degli was approved in 1997 with a first-in-class designation, indicating a novel mechanism of action, and was later permanently recalled in 2018 due to encephalitis. The European Medicines Agency (EMA) found that multiple patients developed eosinophilia, skin rash, and multi-organ involvement or failure suspected to be secondary to immunomodulation, which was only retroactively recognized to be DRESS syndrome. Ipilimumab, approved in 2011, inactivates cytotoxic T lymphocyte-associated antigen 4 (CTLA-4). Cutaneous adverse effects associated with checkpoint inhibitors are varied, and DRESS syndrome is one of the many adverse reactions associated with ipilimumab. Nivolumab and pembrolizumab target programmed cell death 1 (PD-1) and are known to cause adverse cutaneous reactions occurring later in treatment than CTLA-4 cutaneous reactions. Methodology: we searched PubMed for symptoms consistent with DRESS syndrome and monoclonal antibodies approved by the FDA from 2015 to 2019. We excluded studies reporting dermatological complications of reactivation of non-herpetic infection, immunodeficiency-related infection, or injection-infusion site reactions. Studies reporting dermatological manifestations identified as Stevens-Johnson syndrome or toxic epidermal necrolysis, as well as cases reporting only pooled adverse effects in which the offending biologic could not be identified, were also excluded. Results: 2 cases of DRESS syndrome were identified, both following degli treatment. Case worsened and was treated with cyclophosphamide and rituximab. There was 1 additional case of encephalitis without cutaneous symptoms following degli treatment. Drug-induced hypersensitivity dermatitis was reported following treatment with nivolumab in 1 case. This patient developed vesicles and bulli over 30% of his skin, determined to be subepidermal bullous dermatitis with eosinophils on biopsy. Combination treatment with ipilimumab and either nivolumab or durvalumab produced maculopapular rash and bullae in one case and lichenoid dermatitis and blisters in one case. Combination treatment with ipilimumab and nivolumab was also associated with bullae without mucosal involvement 1 month later. Combination treatment with durvalumab and tremelimumab was associated with pruritus and erythematous macules and papules 2 months after treatment. Treatment with ixekizumab preceded new psoriasiform eruptions in one patient, photosensitive cutaneous eruptions in another, and lentiginous eruption in a third patient. Treatment with secukinumab preceded one case of pemphigus and another case of severe, ulcerative lichenoid mucositis. Treatment with dupilumab preceded erythema, pruritus, and widespread skin peeling. Lastly, treatment with brodalumab preceded psoriaform hyperplasia and pustular lesions. Discussion: severe cutaneous reactions of any type reported in clinical trials are very rare, and the only reported cases of DRESS syndrome were in clinical trials of degli. DRESS syndrome itself is a rare condition, but the difficulty in diagnosing it leads to an already reduced rate of identification and reporting, and it poses risks of chronic sequelae and even fatality. The main diagnostic challenge is related to its very low incidence, its high variability among ethnicities, and the variations of its presentation depending on which organs are affected. Fever, rash, and eosinophilia are essential and diagnostic features, but dysphagia, agranulocytosis, and chylous ascites are all possible. The European Registry of Severe Cutaneous Adverse Reactions to Drugs and Collection of Biological Samples (Regiscar) criteria is widely used to diagnose. Regiscar inclusion criteria for potential DRESS syndrome cases require at least 3 out of the following 4 signs: fever above 38°C, enlarged lymph nodes at a minimum of 2 sites, involvement of at least 1 internal organ, or blood count abnormalities. Management requires early removal of the causative agent and treatment with antihistamines and emollients in the mild form, corticosteroids in the moderate form, and plasmapheresis in the severe form. Clinical manifestations are considered a hypersensitivity reaction to drugs when specific circulating antibodies or specifically sensitized lymphocytes are present. In the absence of immunological specificity, these are considered pseudoallergic reactions. In preclinical toxicity studies, type 1 hypersensitivity reactions can be observed following administration of biologics. There may also be a role for sensitization to other allergens, which could explain the delayed presentation. Eosinophilic activation as well as activation of the inflammatory cascade in DRESS syndrome may be induced by interleukin-5 release from drug-specific T cells. The only instance where DRESS was reported by name was in 0.1% of patients receiving 150 mg of subcutaneous degli every 4 weeks for 96 weeks. The reported overall cutaneous adverse events were statistically significantly elevated for necitumumab, and there is some speculation that its large paratope cavities may render it less susceptible to resistance through EGFR epitope mutation, which could theoretically contribute to latent cutaneous adverse effects. In treatment with degli, observed cutaneous adverse events are likely related to the immunomodulatory effects it exerts on innate lymphoid cells, including natural killer cells. Conclusions: degli was the only recently approved monoclonal antibody associated with a diagnosis of DRESS syndrome. Limitations in the diagnostic reliability of DRESS syndrome as a clinical entity complicate reporting, and there may be more cases with associated symptoms not recognized as DRESS syndrome. Confirmed cases of hypersensitivity reactions should be reported in detail, as post-marketing surveillance and risk minimization requirements for biologics are set in place to ensure long-term safety data are collected to assess biologics in clinical practice.